An overview over the current setting. John, please.
So thanks very much for the organisers for inviting me. It's a great pleasure to be here, and I hope that I'll be able to tell you give you some information about what's already been broadcasted as a fairly poorly researched area. And you'll notice that, in fact, I changed the title slightly from extrahepatic cholangiocarcinoma to biliary tract. The data are sufficiently poor on the whole of the biliary tract, let alone extrahepatic cholangiocarcinoma. But I think it gives an overview of what's going on. And you've seen a rather nicer picture than this. This is quite old, and I think I need to update it. But these are the various descriptions of cholangiocarcinoma. There's a bit of an issue with the nomenclature, which has changed, and ICD-10 and ICD-9 differ dramatically in the way in which they classify these. And so part of the issue is we've been comparing apples to oranges, but the other issue is how wide do you extend the concept of biliary tract cancer? Do you have, you should certainly include the intrahepatic tumors, the hilar tumors, and the distal tumors. Gallbladder cancers are included in most series. Should we include ampullary cancer? After all, that does arise from the same epithelium, and they were included in our advanced study, ABCO2. Traditionally, ampullary adenocarcinomas have been included in the pancreatic surgical series and consequently come under a different envelope, but arguably they should also be included in biliary tract series. So that's probably for discussion. Surgeons will have something to say about this. And you've already heard why doing research in this area is difficult. These are uncommon cancers. The studies are small, take a long time to accrue, statistically hopeless. The populations are heterogeneous. You'll see they're quite often HCC and pancreas patients reported in the same series. And consequently, there has been until very recently, there has been relatively little pharma interest. That's good and bad. It means we can't get hold of the new stuff that is exciting and interesting, but it also means they leave us alone to get on with our own studies, and that, in some ways, has been a huge advantage. The disease group, of course, is a difficult one to work with. They're unwell, often elderly. Sepsis is de rigueur. Up until very recently, with the advent of EUS, histology and cytological confirmation has been difficult. A lot of the old series treat patients really without any confirmation, and the disease is not often measurable. And so response assessment, one of the gold standards that we use, is probably the weakest link to outcome. But the patients are out there. So these are all the advanced biliary cancer studies present and published both in abstract and paper form in 2007. And if you add all the patients up, there are about 6,000 patients out there. So it's not that the patients are not out there, it's a question of being organized and getting them into bigger studies to give us reliable outcomes. And so just going back to adjuvant treatment now, part of the issue about fitness for therapy can be illustrated by this. So these are the sort of similar studies. Patients who've had big hepatobiliary procedures, and these are the biggest studies out there. In fact, this one was a liver metastasis study, but I think makes the point that if in studies that have happened very recently, the numbers of patients who are randomized to receive active treatment who didn't actually start active treatment are quite high, and arguably, you know, the SPAC1 study in which 17%, 25 out of 147 patients did not actually start the adjuvant treatment even though they were randomized to it. So arguably, you know, that's not a very good test of your therapy. We've clearly gotten better at this, and in the BILCAP study, which I'll discuss a bit later on, this has fallen, this rate of sort of non-starting has fallen hugely. But this factor here, this non-starting factor, can complicate our studies and our interpretation of the outcome of studies. And so what is the gold standard? What is the gold standard for adjuvant treatment after resection? Well, nothing. There is no gold standard. The data don't exist yet, and I'll explain exactly why in just a second. And surgery only is currently the gold standard. And what sort of results do we get with surgery only? Well, we've heard quite a lot about that just from the last speaker, but this, I suspect, would be considered to be something approaching the gold standard, and recurrence after surgery is more frequent with R1, as we would anticipate, and more frequent in node-positive patients. The question arises as to whether that node positivity is prognostic or predictive, but and something that's going to be very difficult to answer. But we can see from all these studies, so this is cholangiocarcinoma, we can see from these studies that we would anticipate an overall survival in some of these studies of something in the region of 24 to 36 months, somewhere between 2 to 3 years. It's, as I say, worse with tumor stage, that's here, and worse with margin positivity, that's there. Just a brief comment about gallbladder cancer. This is, of course, slightly different. The median survival, the median time to progression of some of these cohorts are similar to cholangiocarcinoma, but if you catch it sufficiently early, the outcome really is extremely good. And consequently, the overall survival for the gallbladder population is significantly better than that for cholangiocarcinoma. There is a much improved R0 rate. The stage, as you can see, is critical. Extended hepatectomy is extremely common in this to improve the R0 rate. So, like it or not, some of these patients are included in the adjuvant studies I'm about to describe. The difference between gallbladder and intrahepatic cholangiocarcinoma is really most marked in terms of the distant recurrence rate, which is hugely higher in gallbladder cancer than it is intrahepatic cholangiocarcinoma. The recurrence rate in intrahepatic cholangiocarcinoma is mostly local, and surely this is related to the anticipated much higher R1 rate. And we've heard an excellent account of the distribution of molecular abnormalities in these cancers. And the question that I would like to ask the speaker, and I'll ask him later, is, you know, here we have a series of cancers that in theory arise from the same molecular, from the same epithelium, and yet here we are, completely different molecular distribution. What's going on? I don't entirely understand that. Although they do appear to have a completely different, or in some cases a very different molecular output, this is the best data we have in terms of how sensitive they are to treatment. So these are the ABCO2 data, and we can see that actually, despite the fact they appear to be molecularly different, the sensitivity to platinum is the same. And that would appear to go for the very small number of ampullary patients that were included in the study. In fact, this was this slightly earlier version of the forest plot that didn't split it up into extrahepatic and intrahepatic, but the same message is clear. I think we saw that figure a bit earlier on today. The sensitivity to platinum would appear to be the same. We do have to do better. These are the CRUK data for intrahepatic cholangiocarcinoma, and the big factor note here really is that the incidence very much equals the mortality. What about adjuvant treatment then? Well, there is of course no gold standard. People use adjuvant treatment. Here are a couple of examples. I don't know if there are any people, Japanese in the audience. These are two Japanese studies, and they have used adjuvant treatment with various combinations of adjuvant therapy in patients with resected cholangiocarcinoma. The toxicity is as expected, and I think but there is no control arm, and I think the only thing you can draw from this is the overall survival, median overall survival, which runs, as we noted before, somewhere between 2 to 3 years. It's these sorts of studies that contributed to what's been a quite influential meta-analysis published in the JCO in 2012. And there's a long list of studies going down the right-hand side there. But and the outcome of this very large meta-analysis was that there would be appear to be some benefit of adjuvant treatment for patients who are node positive and R1 positive. And therefore, they proposed that in ongoing studies, the treatment control arm, you should have a treatment control arm for R1 and lymph node positive patients. That's arguable. And no treatment control arm for R0 and lymph node negative patients. How they were able to derive this kind of information from what are essentially mostly single-arm retrospective studies is difficult. Is difficult to support, in my view. They are retrospective, highly selected for high-risk patients. There's only one randomized study in all of those. And disease stage and grade were not always reported. Quite a few of those came from the SIEs database, and quite often disease and stage are missing from those. And indeed, it stimulated quite a lot of discussion in the JCO, poor evidence to standardize adjuvant treatment. So don't believe it, I think, is another way of putting it. And we know that patients who have node-positive disease do worse. These are again, more SIEs data. But in that series, only a very small number of patients had lymphadenectomy. So how you can derive reliable data from these, I'm really not sure. There is only one randomized study, and these are the takada data from 2002. And you can see this has the classic hallmarks of a slightly mix and match type biliary tract study. Pancreas, bile duct, gallbladder, and ampulla levator patients all included. A good total though of 508 patients. The treatment that they gave is also not something that we would do today. Mitomycin C, some intravenous 5-FU, and then oral 5-FU, which we now know is of absolutely no value. And they compared this rather unusual regimen to surveillance, and the bile duct group that was completely negative. The only positive group in there was in fact the gallbladder group. None of these numbers in themselves are statistically robust. So this is, at best, interesting. It is not informative. It should not tell us what to do next. There are, in fact, other randomized data, and it comes from the SPAC3 periampullary cohort. So SPAC3, I don't know if John Eutonomos is here yet, was the periampullary patients to go with SPAC3 pancreatic patients. So ductal pancreatic patients formed part of SPAC3, and then all the other patients who happened to have a Whipple procedure were also included in this mixed bag of periampullary patients, which included ampullary patients, biliary, and in fact some small bowel cancers were also included in there. But included in this N equals 428 of mixed patients were 96 patients with cholangiocarcinoma resected at Whipple. And you can see that there appears to be no benefit whatsoever of the chemotherapy. But once again, the study was not designed to give us an outcome in terms of what to do with biliary tract patients in the SPAC3 study. But nevertheless, these are in fact the only other set of randomized data that exist for biliary tract cancer patients. Which leads us to the jewel in the crown, as far as, of course I'd say this, but the jewel in the crown as far as we're concerned, the BILCAP study, which is the UK study that randomized patients between capecitabine and observation. And we started this study a very long time ago, in about 2006, and the accrual was surprisingly good. Towards the end, we were accruing something in the region of 80 patients per year in the United Kingdom across the centralized sites. I think centralization has been highlighted, and that helped us hugely in terms of the outcome. The numbers changed. About 2/3 of the way through the study, the SPAC3 study finished, and cholangiocarcinomas resected by Whipple started coming into this study and comprised about 1/3 of the patients. And I'm afraid, and so we know a couple of things. We know the overall survival of the whole group, so that's the whole cohort treatment and control, and that's actually really very good. I mean, that goes out to probably somewhere between 2 to 3 years. We've seen some of this before. And I'm afraid I cannot tell you the answer, because the IDMC are meeting today, and we have a teleconference tomorrow to tell us the results. There are 232 events after approaching 10 years of study out of 447 randomized patients. And this has been submitted as a late-breaking abstract to ASCO, and hopefully we will be able to tell you at that time exactly what is going on. But I genuinely do not know. I don't know, and I in fact won't know until tomorrow anyway. So couldn't tell you. I couldn't tell you. But clearly we're very, very excited about this. What I can show you is the stuff from the open IDMC report. So this is the report that we had in November when we decided to go for the late breaking. And itself, I think, is of some interest. So here's the breakdown of patients through, I mean, both arms are the same in terms of the factors. This is the breakdown in terms of what the cancers were. 29% hilar, essentially what we would call hilar cholangiocarcinoma, about 20% intrahepatic carcinoma, 17% gallbladder, and this 34%, so those are the patients who had a cholangiocarcinoma resected at Whipple, so a cholangiocarcinoma in the pancreas, essentially. And so that I think is a good spread, and will tell us a great deal about those. So 223 patients received the capes. In fact, 222. One patient did not go on to get their capecitabine, but only one, which we're very proud about. Good ECOG performance status, and that also goes obviously for the control group. What else have I got? The tumors, mostly T2 and T3, and about evenly split between N0 and N1. So hopefully that will actually tell us a great deal about what is going on. These are the SIEs, and I was really worried by this to begin with. So I went, the SIE list, as you know, in IDMC reports goes on for about 15 pages. So and I had spent quite a long time digging these out. These are the grade 3 SIEs in the capecitabine arm. And you can see there aren't very many, and I really worried about this for a long time to begin with. But in fact, perhaps it is not so surprising, because after all, these are patients who've been past fit for big liver operations, so anybody with any comorbidity will have been excluded. They will have recovered sufficiently well within 12 weeks of surgery to be considered fit for chemotherapy. So these are really a very, very good patient group, an extremely fit patient group. And essentially, if you haven't had your heart attack during the operation or immediately after the operation, you're unlikely to do so, even though you've been given some capecitabine. So I think that's the big message from here. I still think the numbers are a little bit low, but nevertheless, I'm pretty sure that's what's going on here. And these data will obviously be cleaned extensively before June the 2nd, when hopefully they'll be presented. There were no treatment-related deaths. So I think the one thing you can say that in this population, capecitabine is a pretty safe treatment to give. This is the other piece of information that's coming out. Julianne was here yesterday. This is the Prodige 12 study. The 198 patients randomized between adjuvant GEMOX and surveillance. And and in fact, Julian had the same difficulty that we did. The outcome is surprisingly good. So the events have been very slow to come, and although originally he felt he would be able to present at the same time as we did it at ASCO, he's not able to because he hasn't got enough events. He thinks he will do by the ESMO submission date later on this year. So good luck to him. We talked about that last night. What's up and running at the moment? This is ACTICA 1. This is Dirk Arnold's study from Hamburg. So this is cisgem, so that's the ABCO2 regimen compared to observation. And it's already recruiting in Europe. We have funding for it in the UK, but it's been slow to open because BILCAP has finished actually relatively recently. We had to modify the trial to include gallbladder cancer. And really, the big question mark over here is what happens if either the BILCAP study or the Prodige 12 are positive. Well, if Prodige 12 is positive, the question is how positive. It's a randomized phase 2, really. It's not really a phase 3. And what influence is it going to have on the control arm here? I don't know. We'll have to see how good it looks. If BILCAP is positive, well, if it is, and of course our fingers, toes, and most other things are crossed, you'd have to change the design, and you'd have to change it to cisgem versus capecitabine. Indeed, in preparation for this, the protocol amendment has already been written, ready to go, and that would actually be a really nice study, cisgem versus capecitabine. I think that would recruit extremely well. So that's what's on the horizon. Just a bit of a step back. What about adjuvant therapy in GI malignancies overall? So GI adenocarcinomas, effectively. What do we do? What do we know? Well, oxaliplatin, fluorouracil, and colon is the best story. About 10% improvement in overall survival. Pancreas, very dramatic story. 5 if you gemcitabine, and then SPAC4, which I'm not sure we're going to hear about tomorrow. SPAC4 is due to report at ASCO this year, so that's gemcitabine versus gemcitabine and capecitabine. Esophagogastric carcinoma, capecitabine and cisplatin, yes, that's probably around about 10%. So we anticipate, it's worked in other things. we are optimistic. We'll present at ASCO, Julien will present hopefully at ESMO. There's a small bowel study that's part of the International Rare Cancers Initiative, and that will take a long time to recruit. So don't expect anything too soon. So what have we done? Well, we've actually put bile duct cancer on the map. The international and investigator network has been established. It's now a good network. 2 significant studies have been completed, and hopefully we'll report this year. But there's no standard of care, and the statistically, really good, statistically strong studies don't really exist. We've heard a lot about translational stuff this morning, but translational medicine is actually taking your molecular data and then treating the patient. I don't think that's happened yet. The key to this is, of course, collaboration. Many thanks to all my colleagues listed here. The long list of people on the right is an international consortium, very loose academic international consortium. This is a much better picture. Here we go. So all of these guys, we meet informally at ASCO and ESMO, and it's essentially an information exercise, and everybody is very welcome to join us. Thanks very much for your attention.